All right, let's jump right in. Today, we're taking a deep dive into the really complex world of small vessel vasculitis. Our goal is to break down the specific clinical signs and the underlying pathology that define these pretty challenging conditions.
So let's start with this image right here. This is palpable purpura. Now, this is way more than just a simple rash. It's a clear sign that the small blood vessels in the skin are inflamed, they're damaged, and they're starting to leak. And that really brings up a crucial question. What on earth causes the body's own immune system to turn on itself and attack its own vessels in such a dramatic way?
To get to the bottom of that, here's our plan for today. We'll kick things off with a quick overview. Then we'll get into the details of four key conditions: Churg-Strauss, or EGPA, microscopic polyangiitis, granulomatosis with polyangiitis, and Henoch-Schönlein purpura. Then we'll wrap it all up with a diagnostic review to make sure all these concepts are crystal clear.
Okay, first up, Churg-Strauss syndrome. You'll hear it called that, but its more formal name these days is eosinophilic granulomatosis with polyangiitis, or EGPA for short. And the name itself actually gives us a ton of clues about what's going on here. So let's just break this definition down. Necrotizing simply means it causes tissue death. Granulomas, well, those are these organized clusters of immune cells that your body forms during inflammation. And eosinophilia? That just means you've got crazy high levels of a specific type of white blood cell, the eosinophil. The whole process is usually kicked off by a type 1 hypersensitivity reaction. Yep, the exact same mechanism that's behind common allergies. And that allergic connection is a huge clinical clue. EGPA is really strongly linked with a patient history of asthma and allergic rhinitis. It's also been tied to certain drugs, like the asthma met montelukast. Clinically, you'll often see peripheral neuropathy, specifically a weird pattern called mononeuritis multiplex. On the skin, you'll see that palpable purpura we just looked at, and maybe some subcutaneous nodules. And because this is a multi-system disease, it loves to hit the lungs, skin, and heart. So how do we actually confirm the diagnosis? Well, the lab work is key. A really important blood marker is p-ANCA, which stands for perinuclear antineutrophil cytoplasmic antibodies. But honestly, the most jaw-dropping finding, the one that really screams EGPA, is the profound eosinophilia. We're talking counts that are typically over 1,000 cells per microliter. And this slide, this is the final piece of the puzzle. This is the definitive proof from a biopsy. You can clearly see the blood vessel wall right here, and the tissue all around it is just packed, absolutely swarming with eosinophils, all those little pink staining cells. This incredibly dense eosinophilic infiltration, both in and around the vessel wall, is the absolute undeniable hallmark of EGPA. All right, let's move on to our next condition and see how these ideas start to build on each other. We're now looking at microscopic polyangiitis, or MPA. This one is often recognized by a really classic clinical triad of symptoms. And here's that triad: hematuria, which is blood in the urine, hemoptysis, which is coughing up blood, and purpura. That combination right there tells you that you've got widespread inflammation of small vessels happening in the kidneys, the lungs, and the skin. MPA gets classified as a Pauci immune vasculitis. That sounds complicated, but it literally just means few immune, because when you look at the biopsy, you see very few, if any, immune deposits. Now, it is absolutely critical to be able to tell MPA apart from a similar sounding condition called polyarteritis nodosa, or PAN. This slide lays it out perfectly. MPA involves the small vessels, it always hits the kidneys and lungs, and it's usually p-ANCA positive. PAN, on the other hand, goes for the medium-sized arteries, and all of those features we just mentioned are characteristically absent. Under the microscope in MPA, you're going to see what's called fibrinoid necrosis of the vessel wall and obvious inflammation. But what you won't see are granulomas. That's a huge difference from some of these other conditions. As for what causes it, well, it can be triggered by infections, drugs like penicillin, or it can pop up in patients who already have other autoimmune diseases like lupus. Check out this high-res CT scan of the chest. This is what the lung involvement in MPA looks like. See all those hazy, whitish areas? We call those ground glass opacities. And they basically mean there's diffuse bleeding happening down in the tiny air sacs of the lungs. This finding is super characteristic of MPA, but here's the catch. You also see it in Goodpasture syndrome. So that's a key differential diagnosis you have to consider anytime a patient shows up with both hemoptysis and hematuria.
And that actually leads us perfectly into our third ANCA-associated vasculitis, granulomatosis with polyangiitis, or GPA. Now, you may know this one by its older name, Wegener's granulomatosis.
So GPA shares the hematuria and hemoptysis with MPA. The game-changing difference, though, is the presence of necrotizing granulomas. This vasculitis has a classic trifecta of targets: the kidneys, the lungs, and the nasopharynx. And here's a really important clinical pearl. Even though granulomas are a hallmark of the disease everywhere else, they are typically absent when you do a kidney biopsy.
The manifestations of GPA are really extensive. In the kidneys, it causes this rapidly progressive pauciimmune glomerulonephritis, and you'll see red blood cell casts in the urine. The upper respiratory tract gets hit the hardest, leading to ear infections or otitis media, a perforated nasal septum, and that classic collapsed saddle nose deformity. And in the throat, you can see these characteristic strawberry gums and a dangerous narrowing of the airway called subglottic stenosis. And of course, the lungs are involved too, causing cough, hemoptysis, and pneumonitis.
Now, this slide shows perfectly how different the lung involvement is in GPA compared to MPA. Forget that diffuse, hazy bleeding. GPA classically creates these distinct nodular lesions that then cavitate, meaning they break down and form a cavity in the center. You can see them plain as day on both the CT scan on the left and the chest X-ray on the right. These cavitating nodules are a true hallmark of GPA. So what about the labs? Well, in GPA, they reflect a major systemic inflammation. You'll see anemia, a super high ESR, and leukocytosis, which is just a high white blood cell count. But the most specific marker, the one you're really looking for, is the presence of CANCA, or cytoplasmic ANCA. It's highly associated with this disease.
Given how severe this condition is, you have to hit it hard with potent immunosuppression. The go-to treatments are high-dose steroids paired with heavy hitters like cyclophosphamide, rituximab, or methotrexate to get that autoimmune attack under control. Okay, let's switch gears. We've been deep in the world of ANCA-associated vasculitis. Now let's talk about a disease with a totally different mechanism, an immune complex-mediated disease called Henoch-Schönlein purpura, or HSP. This is, hands down, the most common vasculitis you'll see in kids worldwide. The way this disease develops is really distinct, and it often follows a clear, predictable sequence. It usually starts after the patient, typically a kid, has had a cold or some other upper respiratory tract infection. In response to that infection, the body just goes nuts, producing immunoglobulin A, or IgA. These IgA antibodies then clump together, form these immune complexes that float around in the blood, and then they get stuck in the walls of small vessels. That deposition triggers a type 3 hypersensitivity reaction, and boom, you get inflammation. And that process leads to a very classic clinical picture. You'll see petechia and purpura mostly on the lower limbs. Now here's a huge diagnostic clue. The platelet count is totally normal. This makes it a non-thrombocytopenic purpura. These kids often have terrible diffuse abdominal pain and might have blood in their stool. That GI involvement can even lead to something called intussusception, where the bowel telescopes in on itself. Kidney involvement is common, and so is acute arthritis or just joint pain.
The histopathology is what really confirms the diagnosis. A skin biopsy will show what's called a leukocytoclastic vasculitis, which is a mouthful, but it just means you can see all the broken up bits of neutrophils in and around the vessel walls. But crucially, special staining will light up with predominant IgA deposition, proving the underlying mechanism. And for treatment, the drug of choice to manage all that inflammation is steroids. Whew, okay, we have covered a ton of ground. So let's take a minute to consolidate all that knowledge. It's time for a quick diagnostic review to reinforce the key differences we've talked about. Let's test your knowledge.
First question. Let's say a patient presents with a triad of skin lesions, that asymmetric mononeuritis multiplex, and significant eosinophilia. What condition does that picture strongly suggest?
That classic combination points directly to Churg-Strauss syndrome, or EGPA.
Next up, thinking about the basic pathology of GPA, or Wegener's, how would you classify it? What form of vasculitis is it?
That's right, it's a necrotizing vasculitis, fundamentally characterized by that tissue death and granuloma formation.
Okay, what about microscopic polyangiitis? What are the key things we would expect to see under the microscope? For MPA, you're looking for fibrinoid necrosis and a leukocytoclastic vasculitis, but, and this is key, without the granulomas you'd see in GPA. All right, let's get specific.
When we see these rashes, this purpura on the skin, what exact type of blood vessel is most commonly inflamed?
The answer is the postcapillary venules. That's where the inflammation is typically centered.
Let's broaden out for a second. When small vessel vasculitis happens because of another autoimmune disease, like lupus or rheumatoid arthritis, what is the most common presentation?
That would be a small vessel venulitis, which is inflammation primarily of the venules.
And for our final question, let's consider another immune complex vasculitis, cryoglobulomemic vasculitis. This condition has a very, very strong link to one particular viral infection. Do you know which one it is?
The answer is hepatitis C.